Well, hello everyone, and welcome to our first ever virtual cardiac expedition hosted by the University Hospital Foundation. My name is Carolyn Thompson, and I am so very fortunate to serve as the Director of Philanthropy with the University Hospital Foundation. I want to extend a very sincere thank you to all of you for joining us this afternoon. Today's event is quite popular with over 900 people registered. Please note that this session will be recorded and we will send out the link to everyone who is RSVP'd over the next few days. We cannot hear or see you, but if you do have any questions or comments, please feel free to use the chat and the Q&A box that you'll see on the bottom of your screen. It is now my pleasure to introduce to you Lisa Monroe, who is the Chief Development Officer of the University Hospital Foundation, and who I know has been personally impacted by heart disease, as I'm sure many of you have as well. Lisa?
Thanks, Caroline, and good afternoon, everyone. We're really pleased that you could join us today. I do have my own personal story to share, and in 1995, my father-in-law had life-saving bypass surgery when our eldest son was only 1 year old. And I'm proud to tell you that this past year, when my oldest son got married, he was able to attend the wedding, and we will be forever grateful. Today, you're going to meet Dr. Kevin Bainey, an interventional cardiologist at the Mazankowski Alberta Heart Institute, whose work not only saves lives of people with a life-threatening heart condition, but improves the quality of their lives. And not only will they live longer, but their lives will continue to flourish as they go on. And this is pretty incredible, especially when you consider as little as 10 to 15 years ago, that patients that were living with the same heart condition faced a future of constant fatigue, breathlessness, and eventually heart failure. The condition's called a leaky mitral valve. And I will let the expert Dr. Bainey tell you more about that, but a leak of any kind, whether it's your car tire or a worn out washer in your kitchen, must be repaired as soon as possible. Well, now cardiac surgeons have been doing miraculous work through open heart surgery for years, but only on patients who could survive the surgery itself. If you were older than, say, 70, or if you had one or two health conditions like diabetes or hypertension, or if you had previously suffered a heart attack or stroke, the surgery was not an option. Well, thanks to innovators like Dr. Bainey, that is no longer the case. In a few moments, he will explain to you how cardiac patients with a leaky mitral valve are getting a second chance to live a full, active life with many years, regardless of their age, and in most cases, pre-existing conditions. But before that, I'd like to share something else with you, and that's the role that our donors have played in making this kind of life-saving innovation possible. In 2019, the University Hospital Foundation gave the MAS a $10 million gift in celebration of its 10th anniversary. That $10 million came from thousands of individual and corporate donors, which is why we always say that every dollar you donate makes a difference. With $3 million of that gift, the MAS established its own innovation fund that is geared towards igniting new ideas and furthering research for tomorrow and making room for innovation advancements in patient care today. And it is because of that very fund, the MAS Innovation Fund, supported entirely by our generous donors, that Dr. Bainey can proceed with his program. Before that fund existed, he was actually sending his patients to Ontario to have the procedure done. They would then return to Edmonton under his watchful care. You can imagine how much better things are today for Dr. Bainey and his team, and most importantly, his patients. And before we get to his presentation, I'd like to tell you a little bit more about the University Hospital Foundation. The foundation was created in 1962. We raise funds to advance patient care and innovation at the University Alberta Hospital, the Mazankowski Alberta Heart Institute, and the K Edmonton Clinic. In the ensuing decades, we have evolved into one of the most successful healthcare fundraising organizations in North America. Thanks to incredible generosity of our donors, we have established world-class cardiac and brain care right here at the University of Alberta Hospital, and are home to Canada's most comprehensive transplant program. 1 in 4 Canadians will experience some form of heart disease in their lifetime. And lucky for us, the Mazankowski Alberta Heart Institute is one of the leading complex cardiac care centers serving patients from across Western Canada and Northern Canada. The MAS offers the full continuum of care at any age and any stage, from babies to seniors, diagnosis to rehabilitation. To learn a little bit about how this audience has been impacted by cardiac conditions, we invite you to participate in a live survey. The results of this survey are anonymous and may show us how significant cardiac conditions are within this very group. Jillian, do we have those results?
Yes, absolutely. I'm just going to share the results right now.
Wow. So as you can see, many of you have a real connection with cardiac and probably what brought you here today. It's one of the many reasons we're so passionate about hosting cardiac expeditions and sharing the amazing work of our medical team. Well, it is now my pleasure to introduce our very special guest. Dr. Kevin Bainey is an interventional cardiologist at the Mazankowski Alberta Heart Institute and the Director of Adult Cardiac Catheterization and Interventional Cardiology Laboratory at the MAS. He's also an Associate Professor of Medicine at the University of Alberta Hospital. Dr. Bainey completed medical school and a residency in internal medicine at the University of Alberta. He then specialized in cardiology, becoming chief cardiology resident at the University of Alberta before doing his interventional cardiology fellowship at Harvard University's Brigham and Women's Hospital. Dr. Bainey, it's a pleasure to have you with us today, and the floor is yours.
So let's get started. So again, thank you to the University Hospital Foundation for arranging this first virtual cardiac expedition. I think this is a fantastic venue to be able to explore innovations that are happening at the Mazankowski Alberta Heart Institute. And as mentioned, there's a collaborative, long-standing relationship between the University Hospital Foundation and the MAS, of which many of the stuff that we do could not be possible without the generous donations that you have provided to the University Hospital Foundation. So I'm going to speak today about a very specific condition, cardiovascular condition, that affects millions of patients worldwide. This condition is called severe mitral regurgitation. So what is severe mitral regurgitation? I'm going to try and explain this to you in terms of the physiology from a normal heart and a heart that has mitral regurgitation. So let's start with the flow of the blood across the mitral valve. So in blue is venous blood that is returned to the lungs. That blood is then oxygenated and empties into the left atrium. The mitral valve then opens. This blood goes into the left ventricle. And when the left ventricle decides to contract, the mitral valve closes, and all of this blood passes through the aortic valve into the aorta, which is your main blood supply for oxygenated blood that is given throughout, that is carried throughout your body. So, of course, it's very important for this mitral valve to close so that all of this oxygenated blood gets into the aorta and provides oxygenation for the rest of the body. That's in a normal heart. What happens with this condition called severe mitral regurgitation? Well, again, that oxygenated blood from the lungs comes into the left atrium. The mitral valve opens, and that blood empties into the left ventricle. The left ventricle then contracts, and some of that blood goes into the aorta, but now this mitral valve is leaky. So some of this blood also backs up into the left atrium. What happens when you get this backing up or regurgitant flow of blood into the left atrium? Well, that gets pulled up into the lungs, causing profound shortness of breath. You can also imagine that a lot of this blood that should be going into the aorta to be providing oxygenated blood to the rest of your body A lot of it is now going back into the left atrium, so the rest of the body is also deprived of oxygenated blood. This is the condition called severe mitral regurgitation, which again is synonymous with a leaky mitral valve. So, if you have this condition, what does it mean? Well, if left untreated, only 50% of patients will be alive at 5 years. That's how serious this condition is. In that interim of those patients who are left untreated, they can develop progressive shortness of breath, obviously affecting their quality of life. And again, as time goes on, the left ventricle, which is the main pumping chamber for the heart, decides to fail, leading to progressive heart failure. This is what we want to try and avoid when a patient is diagnosed with severe mitral regurgitation. So, how do we treat severe mitral regurgitation? Well, we actually have very proven, very good surgical procedures to repair or replace the mitral valve when patients develop severe mitral regurgitation. This involves open heart surgery. This is a cartoon of what open heart surgery looks like. Obviously, a very big incision, opening up the rib cage, finding our way to the heart. The heart is then put onto cardiopulmonary bypass. The mitral valve is then either replaced or repaired. The sternum or the rib cage is then closed up. And you can imagine that this open heart surgical procedure, while life-saving, can certainly carry some risk and requires a lot of recuperation after open heart surgery. So as a result, open heart surgery is really reserved to patients who can actually undergo open heart surgery. As we see currently, patients are living longer with comorbidities and simply are not candidates for open heart surgery or would be at high risk of open heart surgery. So now these patients who cannot undergo open heart surgery are left with their severe mitral regurgitation. And remember, what I told you is that really at about 5 years, roughly 50% of patients only are alive. So there's got to be a better therapy that is out there that we can use to avoid this situation, but still improve patients' quality of life as well as perhaps improve their survival. So this is what a transcatheter mitral valve repair approach that we have now started at the Mason-Kowski Alberta Heart Institute. I'm going to take you through this procedure. There will be a movie or a cartoon at the end as well. But what I wanted to highlight with this lesser invasive approach is essentially, rather than going through open heart surgery, what we do is a small incision through the femoral vein in the leg, and we use fancy catheters under X-ray guidance to find our way to the heart, find our way to the mitral valve, and then with a combination of imaging techniques, we are able to find where that leaky heart valve is, and now place a clip onto that leaky heart valve, reducing the mitral regurgitation, improving patient symptoms, and potentially extending their life. This is what the device actually looks like. So a lot of components to this device. This is maneuvers that we as operators have to perform outside of the body. This is the catheter that is in the patient's body. This is the clip device that is attached to the catheter, as you can see magnified here, of which ultimately we deploy in the mitral valve, close it, and the patient is left with this clip, which then reduces their mitral regurgitation and improves their symptoms. So again, walking you through this is that fancy clip device that we used to deploy. into the mitral valve with our catheter. It's closed, and that mitral clip is left in the patient's body forever. This gives you an idea of the size of that mitral clip. So the size of that mitral clip is roughly the size of a dime. So let me take you through an example of what this actually looks like in real life in the cardiac catheterization laboratory. So this procedure, while I've described it as being simple, is not actually very simple at all. This procedure often takes about 4 to 5 hours to complete, requires multiple operators or interventional cardiologists, and again, very fine, meticulous movements to be able to find our way to the heart and deploy this device. These are some of the imaging techniques that we have to use for this procedure. This is what we call fluoroscopy, which is this big machine that is here producing serial x-rays, giving us live images under fluoroscopy to guide our way to the mitral valve. This is an ultrasound of the heart that is done in real time while we're performing the procedure. And we very much rely on the ultrasound images, which are also performed by an echocardiographer cardiologist in the room that helps us position this device and deploy this device in a very safe and effective manner. Again, positioning and deploying this device takes hours to get the perfect position to improve patients' symptoms. So while it does sound simple, again, I want to reinforce that one case alone sometimes takes us up to 4 to 5 hours to complete. So, great, we have this option of a less invasive approach to treat patients with mitral regurgitation whom cannot undergo open heart surgery. Great, it is out there, but does it actually work? And does it actually improve outcomes? And what you'll realize in cardiology is that we are very evidence-based when it comes to practicing medicine. At the Mazankowski, we pride ourselves on being very evidence-based in the therapies that we provide for patients. So although this device sounds extremely promising and it seems mechanistically should do the trick, we have to evaluate this in a large clinical study to be able to definitively say, yes, this makes sense, and this is indeed doing what we think it is supposed to do. So the large clinical trial that was developed is the COAP trial, of which we were a participating site and actually enrolled the last patient in this study. And it was designed to answer 2 questions. So these were patients who cannot undergo open heart surgery, so very sick to begin with, had severe mitral regurgitation, and standard of care at that time is medications only versus testing this experiment of the mitral clip with medications. And the 2 questions we want to answer is, are we improving quality of life, shortness of breath, heart failure symptoms? And 2, can we actually improve patient survival with this therapy? So this was the study, and these are the results. Out to 2 years, patients who are just treated only with medications without the mitral clip device have a very high risk of hospitalization for heart failure with shortness of breath. In those patients who actually got the mitral clip device, there was a dramatic reduction in hospitalization for heart failure due to severe mitral regurgitation. These are fancy statistical terms, but essentially there was almost a 50% reduction in the risk of patients being admitted to hospital with heart failure and shortness of breath. Very profound results, suggesting that this therapy does improve quality of life symptoms, improves patients' shortness of breath. So great, we've got a good therapy that can keep patients out of hospital and improve their shortness of breath symptoms. The next question is, does it save lives? So here, again, in a randomized fashion, this is patients with medical therapy alone without the device. And again, I want to reinforce that these are sick patients who cannot undergo open heart surgery. This is randomized, clean data showing you that at 2 years in these patients who are sick, roughly 50% of patients are dead. That is quite profound out to 2 years. With the mitral clip, that improvement in survival is seen and is statistically significant, endorsing the fact that this therapy does improve survival long term. So 2 wins for this therapy in a large randomized clinical trial, which the MAS had participated in, which led to a novel therapy that can now be used for these patients. So, being part of this clinical trial and thinking about this more in depth and realizing that there are so many patients out there who have this condition and cannot undergo open heart surgery, we felt that we needed to review the literature, explore these results, and potentially contemplate an algorithm that we can put together to incorporate this therapy. This was published in the Canadian Journal of Cardiology. I was the senior author on this publication. And yes, we showed the benefits of the mitral clip procedure based on clinical studies, but we then went a step ahead and we said, you know what, this therapy is needed for patients. So we created a proposed Canadian algorithm for clinicians to follow for those patients with severe mitral regurgitation to say, okay, in those patients who cannot undergo open heart surgery, we really need to offer this therapy. So I'm not here to say that this is the only therapy for severe mitral regurgitation. I think patients who can undergo open heart surgery to repair or replace this valve is an excellent surgery. I'd also like to promote one of my surgical colleagues, Dr. Jeevan Nagendran, who has developed a surgical procedure whereby he can repair this mitral valve without having to undergo a traditional sternotomy, meaning opening up the rib cage, but he can actually go through the side of the chest. That has been quite novel and another step forward for the Mazenkowski Alberta Heart Institute. But there are patients who simply can't undergo any kind of surgery. And these patients, we've suggested, need to be optimized with medications and then reevaluated. And then, of course, if they are candidates, they should undergo the mitral clip procedure, again, if they cannot undergo open heart surgery. So this has been established as a Canadian algorithm that was published in the Canadian Journal of Cardiology. So let me take you to a patient. This is a patient that I remember vividly. He was a gentleman in his late 70s who had a lot of other clinical issues. He, as a result of those clinical issues, and he had severe mitral regurgitation, he could not undergo open heart surgery. He was too high risk. This gentleman had severe mitral regurgitation for over 2 years, and it got to the point where he could not even perform his activities of daily living at home without being short of breath. He could only walk a few paces in his kitchen without being short of breath. When lying down at night, he had to get up periodically at night because of shortness of breath. He felt like he was drowning. This is his wife, who was a nurse and really provided all of the care for her husband. And you can imagine how stressful it was for her as well to have to see her husband suffer with this progressive shortness of breath. And so he came to me, to consider this procedure. And to be a candidate for this procedure, you have to go through an entire workup to make sure. And he fit all of those check boxes. And so he ultimately underwent the procedure at the Mazankowski Alberta Heart Institute. This is our hybrid OR room, which again, I shout out to the University Hospital Foundation, which helped fund this hybrid room, which is a combination of a cardiac catheterization laboratory and a surgical suite. And so he underwent this procedure. This case took me about 4 hours, and ultimately had a successful procedure done. He left the hospital the next day, and this is me seeing him in follow-up. And you can see on the top right of your screen, this is his x-ray. And this is the x-ray of his heart. And you can see that we actually had to place 2 mitral clips on this gentleman's mitral valve to reduce his mitral regurgitation. And this is what it looks like, and it stays in the patient's body forever. And so in follow-up, it has been a dramatic 100% improvement. He's able to perform his activities of daily living. He goes for walks in the mall with his wife. It was just an outstanding difference for him in terms of his quality of life. And without me mentioning it, that was the first thing that he came back and told me, was that him and his wife told me that it's amazing how the quality of my life has improved with this therapy. Otherwise, if this didn't exist, he would not have been a surgical candidate and would have just developed progressive shortness of breath. And you can imagine how that can feel as a patient to be suffering from shortness of breath. So I will end off with a video clip procedure of how this is actually performed. So I'm just going to jump here. So, and I'll kind of walk you through this as well. So this is the left ventricle. That blue blood is the mitral regurgitation, or that blood flowing back into the left atrium. This is, again, the device that we use to deploy this mitral clip. This sits inside of the body. The other part is outside. We go to the femoral vein, and with wires and catheters find our way to the heart. We have to poke through something called an intraatrial septum to deliver our catheter into the left atrium. This is the mitral valve down below. And through this catheter is where we now deliver our mitral clip device and position it appropriately to try and address regurgitation. Again, you can imagine the very subtle, finite movements that need to be done under imaging and X-ray guidance, because this is not open heart surgery. We can't actually see inside of the heart. We're relying on imaging and X-ray guidance. And so a combination of those allows us to turn and maneuver this clip to place it across this mitral valve. So here's the mitral valve, left atrium, left ventricle. We then advance the clip into the left ventricle. And now we have to try and capture these leaflets, which are moving in real time, to be able to reduce the mitral regurgitation. This is an example of where, if we're not happy, then we can reposition, open it up, close it, open it up, close it, to find the ideal position. Here you can see that blue mitral regurgitation is gone. We confirm that with a bunch of imaging techniques. And then once we are happy and satisfied, the clip device is released, as you will see here shortly. And then this device is then taken out of the patient's body, and the catheter is taken out of the patient's body. Again, this work is all done through a small incision in the femoral vein, of which at the end of the procedure, we suture with a couple of sutures, and the patient then goes to our intensive care unit. And most commonly, is discharged the following day home. So I will stop sharing my screen and open to any questions pertaining to this or anything under the realm of cardiology. I also wanted to mention that I think I mentioned it at the beginning, but again, I just wanted to reinforce that, the donation dollars that has been provided to the University Hospital Foundation makes a program like this possible. And the current fiscal environment that we are, under in Alberta has made it extremely difficult to provide innovation. And it's the Hospital Foundation that has really helped us through this Mass Innovation Fund, which was a competition, but allows us to explore these innovative strategies and technologies and move ourselves ahead as a heart institute. And I want to mention that the mantra of the Mass and Kelsey Alberta Heart Institute is leadership and innovation, and this falls under both. The fact that this is now the only program in Alberta that will service all of patients in Alberta, I think is an amazing feat. And again, could not have been done without the University Hospital Foundation. So thanks.
No, thank you. We really appreciate everything that you do and all the amazing work that you and your team have done. And as a proud Edmontonian, it makes me very excited to know that we have this care right in our backyard. And thank you for your support of the foundation. At this time, I want to introduce my colleague, Prince Osai, who's a philanthropy officer at the University Hospital Foundation, and he is going to manage the Q&A today. Prince, over to you.
Thank you, Lisa. Thank you so much, Dr. Bainey, for this exciting presentation and for taking us into the world of a cardiologist and an interventionist. We appreciate this so much. So this is the part where our audience get to ask the doctor the questions. I'm just going to be the intermediary and read out the questions aloud to Dr. Bainey. If you look at the bottom of your screen, you would find a Q&A dialog box. This is where you're going to type in your questions. I'm going to read them to Dr. Bainey, and we do have about 15 minutes for our questions today. And should we not be able to get to all the questions this afternoon, we do promise you that we're going to capture all the questions, get the responses to them, and send them to you in an email format by next week. So please keep your questions coming. So the first question is, Dr. Bainey, this came from Linda. Linda is asking that she has a permanent IVC filter. Would she be a good candidate for this procedure?
Really good question. And so with an IVC filter, and just I'll kind of explain things to the audience. This is a mesh type of device that is put into the venous system, into the inferior vena cava, which prevents clots from the legs getting to the heart. And so with the mitral clip procedure going through the femoral vein, that would be would prevent us from using our devices to cross that IVC filter and get into the heart. With that being said, it can be done because it is fenestrated, but puts the IVC filter at risk of migrating. So I think high-level summary in that particular scenario is it would be unlikely that we would be able to perform this procedure with an ongoing IVC filter in place.
Okay. Thank you. The next question also from Karen.
I should interrupt and say one other thing though, but now that I'm thinking about it, so is that you can actually potentially retrieve the IVC filter, get it out, do the procedure, and then put it back in. So that would be another option.
Okay, thank you. So, does the mitral clip fully stop the leakage, or does it just reduce it?
Yeah, so it depends on the outcomes that you get at the time of the procedure. So The answer to that question is that it severely reduces it. Okay, it doesn't eliminate it, but it severely reduces it. If you can get it to the point where you have mild mitral regurgitation, that's fantastic. And we know that mild mitral regurgitation, patients can live a lifetime with that and not cause any issues whatsoever.
Okay, wonderful. Kevin is asking, how do the results change after 2 years?
Yeah. So the long-term follow-up for this device is still ongoing. As you seen, we do have the outcomes out to 2 years based on the clinical trial. There is some registry data out to 5 years that show that this clip still holds up very well. To answer your question and know how does this device hold up in 10 to 15 years, that is unknown. But remember that this device is reserved for patients who are at high risk or cannot undergo the mitral clip procedure, cannot undergo open heart surgery. And so, if you have somebody who you're, doing this in their mid 80s, are you going to get, 15, 20 years out of it? Well, I don't think patients are looking for that, right? They're looking for improvement in their symptoms at that point in time, which, this device certainly offers.
Thank you. Ken is asking, he just had an aorta valve replaced through an open heart surgery.
Yep.
Could this technique have been used to replace his aorta valve?
That is a fantastic question. So the short answer to that is this whole journey of trying to deal with heart valve disease in a lesser invasive approach really started off with the aortic valve. And so it is something called TAVI or TAVR, just transcatheter aortic valve replacement. And what that means is basically using catheters like I showed you through the groin, but here through the artery. These valves can be deployed with a catheter, crushing the native valve and opening a new valve in that area. So the short answer is yes. Now, the long answer is that it has taken 15 years of research to prove that these valves indeed do well compared to surgical valves. And so we do have the data right now that suggests that these valves hold up very well. And initially, were just reserved for high-risk patients or patients who cannot undergo open heart surgery. Has now shifted to moderate risk patients. And now there's very good data to suggest that it does just as well in low-risk patients. So, do I see a point in time in the future that the aortic valve will be done solely with a transcatheter approach? I do. I do think that will inevitably happen. But as it exists right now, it's a spectrum of how we use this. So these valves are really reserved, at least in Canada, for the patients who cannot undergo open heart surgery, high risk, or maybe intermediate risk. But the low risk patients, certainly surgical aortic valve replacement has held the test of time. Patients do very well with it. And again, our surgical program has become innovative in terms of reducing the size of that incision to help for patients' recovery. And so right now, patients are still getting surgical aortic valve replacements, but it's really in those patients who are low risk, we know can recover quite well. Certainly the patients who are at high risk, those patients are now routinely undergoing a transcatheter approach. And so because of the development of that technology on the aortic valve, that's how the thoughts about trying to deal with a mitral valve came into play.
I think this is a question on everybody's mind. How many of these procedures are done in Edmonton, and could we be doing more?
Yeah, so the short answer to that question is, again, this procedure is reserved for a very special population. Again, the University Hospital Foundation has allowed us to start up our program. So, how many cases are we looking at in a year? I think we're right now very selective of the cases that we bring through to get the ideal results. But that will build over time, just like the aortic valve story. At the end of the day, money is always an issue. And, it's, if we had unlimited resources and unlimited dollars, I think it would be a completely different story. This device is very expensive, and hopefully the price goes down in time. But in our provincial and Canadian system, and I do think we do a good job, this is worked into the armamentarium of treatment of mitral regurgitation. And again, patients who can undergo surgery should, because that has stood the test of time. So short answer is we, are starting up and we're going to build upon our program, and this is here to stay, and the numbers will increase undoubtedly. I can tell you that I've received a ton of referrals already.
Thank you. So Wayne is asking, he just received a newish aortic valve, a bovine.
Yeah.
About 10 years or so by Dr. Kushal.
Yeah.
At some point, would this type of repair be available if he needs it?
Yeah. Another fantastic question. Answer is yes. So in patients who have had a prior aortic valve replacement with a bovine aortic valve, there's always a chance of that valve re-narrowing, of which I'm sure he or she has been told. And so that usually starts happening at about 10 to 15 years after the surgery, if it does happen, okay? And that's what we call restenosis of the aortic valve. And if that happens, then that we have what we call a heart team discussion, where interventional cardiologists and cardiac surgeons meet together to discuss the patient in totality. And in those patients, we know that a second open heart operation is much riskier. And so if that risk is high, then undoubtedly they would end up getting a TAVI valve, meaning that a transcatheter aortic valve that can be put inside of that surgical valve. That is done routinely now with the Mass.
You did talk about cost, and Dawn is asking, how much does the mitral clip cost?
So the device itself, and that's not taking into consideration physician time, nursing time, resource time, just simply the price of the device is $20,000.
Thank you. So Gloria is asking, is there a similar procedure for the tricuspid valve?
Yeah, that's an excellent question. And so this is another avenue that is currently being explored. And actually, Canada is leading the way in this. So there's ongoing research currently that is actually using this mitral clip device and placing it on the tricuspid valve. Cases have been done successfully in patients. There is an ongoing randomized study to see indeed if this is feasible and works and improves patient symptoms. My feeling is that yes, it will. And it's not for prime time right now, but once the research is complete and shows efficacy, yes, you will have a clip type device for the tricuspid valve.
Thank you. So the question that came through is, what were the concerns why the body entry is not being done closer to the heart, but rather from the leg?
The port of entry, yeah. So I guess the answer to that question is we need a large-sized vessel to be able to put our equipment in to get to the heart. And so, the large-sized vessels in our body are the venous or the IVC, the inferior vena cava, or the aorta. And so the aorta is used for the aortic valve, and the IVC, inferior vena cava, is used for the mitral work. So it's because of the size of the equipment that we need a big blood vessel to be able to access. So in other words, we can't do this through, a little artery in the wrist or, a little artery in the arm. It has to be done in a big, vein in the wrist or the arm. It has to be done through a big blood vessel. So that is the main reason why. There are other approaches. We can, particularly, I have seen patients where this has been done through one of the veins in the neck, which tend to be a lot larger. But in general, it has to do with the size of the vessel.
Thank you. So Karen is asking, is this procedure usually done under general or local anesthesia?
Yeah. And so because of the length of the procedure, so again, these cases take often, 4 to 5 hours to do. And the fact that we also have to use a fancy ultrasound, which is called a TEE. So it's a probe that is put into the esophagus. And then from the esophagus, we're able to use ultrasound to actually see the heart in fine detail. So because of those two reasons, patients are intubated or do have to be put on, have to be intubated to be able to complete the procedure. So for the patient, we do require an anesthesiologist. They are completely sedated, knocked out, intubated under general anesthesia. And then at the end of the procedure, literally on the operating table, the breathing tube is taken out.
Is there a possibility of post-operation failure of the clip itself?
Say that again?
The possibility of a post-operation failure of the clip, yeah.
Yeah. So yes, it is. So everyone always worries about whether or not the clip will embolize, meaning leave the mitral valve and go through the aortic valve and end up somewhere in the rest of the body. That has never been reported in Canada, I should say. So that is extremely rare for that to happen. Yes, the mitral clip can fail. It could look really good at the end of the procedure, and for whatever reason, it's not doing well long term. That is rare to happen, but it can happen. And also what's important to understand is that if it does happen, you can always have another procedure done again.
Okay. And Roberto is asking, what is the material that is used for the clip?
It is, how to explain it? It's there's a metal component to it, but there's also a fiber that's attached to the clip itself, which is very, how do I put it? It's very friendly to the blood. And so it doesn't cause, blood clots on it or anything like that.
Okay. We've got time for 2 more questions. Kathy is asking, what was the situation with your patient that deemed 2 clips to be administered?
Yeah. So you can put more than 1 clip right away. There have been cases that have had 4 clips. It depends how big your mitral valve is, but that's the beauty of us doing this in real time. So that, let's say I put 1 clip on and then we assess with ultrasound the degree of the mitral regurgitation. And let's say I've reduced it, but I've gone from severe to moderate mitral regurgitation, and I really want mild. I want that to be really, really mild. Well, then at the time, while the patient's on the table and intubated, I can put a 2nd clip. I can put a third clip and to get to that mild form. So in this guy, he had quite a big mitral valve and I wasn't happy with the result with the first clip. It did improve things, but I thought that I could get an even better result with a second clip, and certainly I did. So that was the reason.
Wonderful. The last question is coming from Roger, and he's asking, with today's nanotechnology, do you see more advancement in the months and years ahead?
With what? Sorry again?
Nanotechnology.
Okay. Yeah, I do. I do. You know, pertaining to valve disease, maybe. But I think in general with cardiovascular disease, yeah, I do think that there will be a role for nanotechnology. And, you know, for cardiology, for cardiovascular care, you know, I see that being front and center because, again, we are very much evidence-based in terms of practice and always pushing the field. And so, you know, things like nanotechnology, things like machine learning and artificial intelligence in terms of predicting what will happen with patients, who will develop mitral regurgitation, who won't, who will develop a heart attack, who won't. We're constantly exploring those issues. We're actually exploring those currently using AI, ML, or artificial intelligence, machine learning algorithms. So I think that the high level summary is in cardiology, we are always pushing the agenda for research and trying to improve patient care. And that is very much front and center at the Mazankowski Alberta Heart Institute. It is very front and center for our interventional program, our interventional cardiology program at the Mazankowski Alberta Heart Institute. You know, we are one of the few centers across the country where, as an interventional cardiologist, or our group, is very much focused on research and improving cardiovascular care. And that's also because, you know, we fall under that, you know, what I consider the premier heart institute in Western Canada.
Dr. Bainey, thank you, thank you, thank you. This is all time, that much time we have for the questions today. I do promise our audience that we're going to get the responses to the rest of the questions and we will send them to you by email. Thank you for joining us this afternoon. I will pass it on to Caroline.
Thanks, Prince. Those are some amazing questions. Thank you for all of the questions that came in. On behalf of the University Hospital Foundation, including Dr. Bainey, Lisa, Prince, Jillian, and myself, thank you so very much for your time and your active participation. We hope, and I think we're pretty sure that you found today's session very informative. Within the next few days, we will send you a very short survey to let us know how we did and what other areas you might be interested in exploring with us in future expeditions. We will be sending the recording from today's cardiac expedition to you. So if you do need to learn more, please do reach out to a member of our philanthropy team. And as Dr. Bainey alluded to earlier, we do need community support for the work of the doctors like Dr. Bainey to continue. The role you play is invaluable. If you'd like to learn more, please do visit our website at give2uhf.ca. And please join us for our next virtual cardiac expedition, which will be held later on this month on February 25th at 4 p.m. And this expedition will feature Dr. Jayan Nagendran, and he will be presenting on transplantation and the ex vivo organ support system. Now, before we go, I wanted to tell you about our 6:30 CHED Heart Pledge Day, which is presented by Durabuild. This is our annual radiothon for the Mazankowski Alberta Heart Institute. So on February 24th, please tune in to 6:30 CHED from 6 a.m. to 6 p.m. to hear some more news and stories from our other physicians, from medical researchers, frontline healthcare providers, and our patients who will share some of their inspiring stories to help raise awareness about this world-class cardiac institution that we call the MAZ. Our goal at Heart Pledge Day is to raise $350,000. So please tune in and tell your friends about this important fundraiser. So thank you again for joining us. This does conclude our formal presentation. As I mentioned, again, we have our next virtual cardiac expedition on February 25th at 4 p.m., where you'll meet one of the doctors responsible for transforming lung transplants for patients around the world. So I don't think you're going to want to miss that one. And finally, we're going to leave you with a short 1-minute video entitled, "What if you could actually save a life?" Thanks, everybody. Have a great evening.